Pleasure for me to introduce my dear professor, Professor Hamdi Abazim, Head of Clinical Ecology Department, Cairo University. Professor Hamdi will talk about brain met in HER2 positive breast cancer population, doing a better job.
Yes, hello once again. I will not be long this time. That's a sad story in the brain metastasis in breast cancer, although it started to be resolved a little bit. We have three pivotal questions relevant to my talk. How common are brain metastases in breast cancer? And the second question, does HER2 positivity increase the risk for brain metastases? And the third, does trastuzumab treatment further increase the risk of brain metastases? And the answer is breast cancer, probably in the lifetime of patients, around 15% of patients with metastatic breast cancer will develop brain metastasis at some point in time. And although in the post-mortem studies, there was again another 15% who proved to be harboring brain metastasis without being manifested. So all in all, probably, if we include the manifest and the occult brain metastasis, we're talking in the range of 30%. And they have been linked during the era of prior to the genetic profiling of breast cancer. We used to link this definitely with young age, with large metastatic tumor, and the presence of lung metastasis, ER negative disease. But now we know that probably it is the basal phenotype and HER2 enriched subtypes, they have the highest risk of brain metastasis. And actually the emerging HER2 connection, it came from the lab in the preclinical model. Overexpression of HER2 increased the brain colonization by around 2.5 to 3 folds compared to HER2 negative cell lines. So the question of whether do we have similar to what we have in bone metastasis, a story of seed and soil theory, does it really apply to the brain metastasis? Actually, it doesn't really fit like what we have in bone metastasis. But in a way, we have certain reasons for the organotropism of HER2 positive breast cancer into the brain. And actually, this is related to the expression of certain chemokine receptor called chemokine receptor 4, which has been recently shown to mediate the movement of breast cancer cells through the blood-brain barrier into the brain, where there is an excessive amount of its specific chemokine, which is stromal cell-derived factor 1 alpha. And actually, any disease any cancer which have high expression of chemokine receptor 4 will develop more metastases in the organs like lung, liver, bone, and brain. So what happened then in HER2 positive breast cancer? We knew that HER2 positivity induced significantly higher expression of chemokine receptor 4, 3 folds more than HER2 negative. And we know that the brain is a non-specific receiver of chemokine receptor 4 positive cells. This interaction actually, which is essential to develop the metastatic process at any organ, seems to apply in HER2 positive breast cancer and the brain, such that the HER2 positivity and the brain will have something like this. In the brain, we have selective upregulation of stroma-derived factor 1 alpha, and the HER2 positivity will induce overexpression of chemokine receptor 4 for the breast cancer cells, and this will get the breast cancer, circulating breast cancer cells into the brain to induce the colonization. However, another important issue related to the development of breast cancer in HER2 positive subtype is also the increased vascular endothelial growth factor production by mTOR activation in HER2 positive breast cancer. So we have two players, at least we know about two players. We know the responsibility of the overexpression of VEGF by mTOR activation and we know the expression of chemokine receptor 4, together they may be responsible for the development of brain metastases at a higher frequency among patients with HER2-positive breast cancer. From the clinic, we can have the proof of this concept actually. In the first trial that showed this, it was published more than 20 years ago, that showed that patients with HER2-positive breast cancer, they have significantly higher brain metastasis incidence as first site of metastasis compared to HER2-negative. And you can see here the first site for development of metastasis in HER2-negative patients was 0.4% versus 4.3%, which is 10 times higher. And that was before the trastuzumab era. Our own data set, which we presented last year in the ASCO breast cancer, we included more than 2,300 patients. 96 cases of them, they developed they developed brain metastasis. And here we are, the brain metastasis-free survival was the shortest significantly among patients who were HER2 positive. And in fact, the most convincing data came from a larger data set with prospective redoing of all the biomarkers for breast cancer, and patients, they were followed up for a median of 15 years. So this data set actually is extremely reliable because the biomarkers were done in a prospective manner, and it showed us that at 15 years as median follow-up, patients with HER2 enriched, which is HER2 positive, ER negative, the incidence of patients in the metastatic phase, in early breast cancer, at 15 years, around 15% will develop brain metastasis, and that is followed by the basal-like and triple-negative, and the least was in luminal A. So now, according to our description of the disease, your patients with luminal A and lesser extent, and to less extent the luminal B, they are probably secured if they have early breast cancer to develop brain metastasis at 15 years, in contradistinction to the HER2 enriched breast cancer and basal-like. So, after the introduction of trastuzumab treatment, we have further what we call trastuzumab storm in the development of brain metastasis. And also we have seen this not only in the patients treated by trastuzumab in the metastatic phase, but as well in patients in the adjuvant phase. And our group, among others, we were the first to report a very high incidence of brain metastasis in patients treated by trastuzumab-based chemotherapy therapeutic regimen in metastatic phase of the disease. And actually, even in the adjuvant studies, the meta-analysis done showed that for the 3 large studies, they did not include the BCRG-06. They showed that the incidence of brain metastasis in trastuzumab-treated patients were higher among patients treated by trastuzumab in the adjuvant phase compared to those who did not. Although, of course, the incidence of overall relapse was significantly better in favor of trastuzumab. So the blame, of course, is for 2 things: for a disease that go more specifically to the brain, and a molecule that is very effective in the extracranial domain, while it has a very big molecular weight. It is in the range of 140 kilodaltons, and actually the combination of a tumor type that goes specifically to the brain, high potential to go to the brain, and treatment that does not penetrate the brain, but it is very effective outside the CNS. This creates the opportunity, of course, to have more and more patients with brain metastasis. Okay, is it worthwhile to give systemic treatment after brain metastasis and whole cranial radiation? Do we lose hope in patients treated by whole cranial radiation and stop the systemic treatment? Because we know that the prognosis is poor. We don't have a real prospective data set in this area, but we have plenty of retrospective analysis. All suggest that if you keep on, after the development of brain metastasis and whole cranial radiation, if you keep on trastuzumab, definitely you improve over no trastuzumab after whole cranial radiation and probably the best data set described was by Dr. Shahina Dawood. She's sitting in front of me. I don't see her now, but that's her data set from MD Anderson Cancer Center, and they showed that if you, after the development of brain metastases, it's advisable to keep the patients under anti-HER2 treatment, in this case by trastuzumab, of course. We need to differentiate between actually a case of brain metastasis in HER2-positive breast cancer and a case of brain metastasis with triple-negative breast cancer, because they have brain metastasis, but the prognosis and our capabilities now are totally different, where actually the control of extracranial disease at the time of brain metastasis is probably the rule in HER2-positive breast cancer. It is very uncommon to have patients with triple-negative breast cancer with a real control of the disease outside the brain. The median survival of patients who develop brain metastasis actually is improving dramatically in patients with HER2-positive breast cancer, while it's still in the range of few months in triple-negative breast cancer. But more importantly and more seriously, actually, patients with HER2-positive breast cancer will be more and more dying because of CNS progression, and we don't have a real solution at the present time. So, how can we help this? Of course, we can talk about early detection of brain metastasis. We can talk about prophylactic whole cranial radiation, having had the model of small cell lung cancer, the successful model of prophylactic cranial radiation. However, actually, we have ongoing trials trying to check whether early detection by regular MRI every 4 months will really do something good for the patients. We don't have the answer as yet. We have data from Poland that suggests that it may improve the intracranial disease, but it did not improve the overall survival. As for the prophylactic whole brain radiation therapy in the responders with Herceptin, we have 2 ongoing trials, and for some unknown reason, actually, the Anglo-Celtic study should have been presented during the last San Antonio, but it did not. So we don't know whether prophylactic cranial radiation is advisable or not. We have another trial asking the same question from the Cross Cancer Institute in Canada. It's a smaller trial addressing the same point. The 2 trials, they finished accrual, but we are waiting for the results. Till then, of course, this is not to be recommendable to give whole cranial radiation as a prophylactic treatment for brain metastasis in HER2-positive disease. Better systemic treatment, of course, should be considered, but we have a real problem, which is the blood-brain barrier. And if you see the structure of the blood-brain barrier, it's very unique compared to any vascularity within our bodies, where the endothelial cells, they are very tightly concealed together. So they have very tight junctions, which do not allow the passage of the water-soluble material. And it is almost leak-proof endothelium, and only small molecular weight molecules can pass by diffusion less than 200 daltons. More difficult, actually, we started to know that the cerebrovascular endothelium, that's the endothelium actually, it is very rich in the expression of multiple drug resistance protein, and they will definitely get any drug from the cell into the circulation. At the moment it goes to the cell, it will be pumped out again to the circulation. So the majority of chemotherapeutic drugs will be subjected to efflux back into the circulation by the action of endothelial transporters. And it is estimated that the blood-brain barrier blocks approximately 98% of all small molecules and 100% of the large molecules. However, when we have a tumor, it's no more blood-brain barrier. Now it is called blood-tumor barrier. This term is recently introduced to describe the changes introduced into the blood-brain barrier as a sequence of development of brain metastasis. What's important is to tell you that the blood-tumor barrier is definitely much more permeable compared to the blood-brain barrier, but still it impedes an adequate cancerous dose or concentration of the chemotherapeutic drugs into the brain. We have a very good group, the Lockman and his colleagues. They have done a beautiful job to tell us what's going on through the blood-tumor barrier. Actually, they described that a drug like paclitaxel can have a concentration like 10% compared to its concentration in other metastatic sites. And they have shown us that that's radioactive paclitaxel actually. It is concentrated in the metastatic lesion much more in the primary brain tumor. So that's why in certain cases you can give systemic chemo, even the CMF. There are reports to tell you that chemotherapy can go, but probably after a while, when the tumor shrinks, the blood-tumor barrier will be less permeable, so they will progress rapidly. So lapatinib actually is, as you know, is an anti-HER1, HER2 potent dual inhibitor, and it's small molecule. It's not that small, by the way. It is less than 1 kilodalton. That trastuzumab is 148 kilodalton. So it's much smaller than trastuzumab, but still it's not small enough to get a negative diffusion into the brain. Lapatinib, the question, does it really go to the brain metastasis? The same group, as I told you, from MD Anderson, they showed us that lapatinib concentration in the tumor is much higher, around 15 to 18 times higher in the tumor compared to the normal brain. And in quantitation, actually, if your patient has large, that's to say more than 2 centimeters brain metastasis, the concentration of lapatinib is in the range of 1/3 of that of a lung metastasis, for instance. However, the development of studies for brain metastasis really suffered from very poor design of the studies. And actually, the first generation of the studies, they utilized lapatinib in patients with brain metastasis after failure of whole brain radiation, and they gave the drug as a monotherapy. And of course, we know that the anti-HER2 drugs, whether in the brain or outside the brain, they don't have the best circumstances to be used as monotherapy. And that's why there was no much enthusiasm in the 2 phase 2 trials. This phase 2 trial is probably the largest phase 2 trial ever in brain metastasis. And they reported that the response rate objective was very modest, around 6%. And we have some minor responses, less than 50%, but the time to progression was not impressive at all. Actually, if we go more and know that lapatinib itself is a substrate for drug resistance protein. So the drug resistance protein, the P glycoprotein, actually will get lapatinib outside the brain parenchyma, and that's one of the problems of lapatinib to cross the blood-brain barrier. However, in experimental model, and that's very important, lapatinib was able to suppress the P glycoprotein function. So probably lapatinib can be a good partner with other drug, and we have seen this in the preclinical models. It can improve the going in of paclitaxel and liposomal doxorubicin into brain metastasis. And these findings may definitely suggest that the use of lapatinib in brain tumors, in brain metastasis, should be in combination with chemotherapy and not a single agent. And by the way, that's how we treat the metastasis everywhere in the body in HER2-positive breast cancer. We don't give anti-HER2 alone. And in the same trial pivotal trial of brain metastasis, when patients failed under lapatinib and you added capecitabine, you improved dramatically the response rate and time to progression in the patients treated by the combination. And actually we have not much, but we have several trials using the combination of lapatinib and capecitabine in patients with HER2-positive breast cancer with brain metastasis. And with the exception of the study by Dr. Bachelot and his colleagues, you will find that all the studies, they gave this combination after failure of whole cranial radiation. Maybe that's too much of a delay to use this combination. Maybe it will be better to use it earlier. And that was what was done by the French group in the landscape trial when they give this combination as first-line treatment. They have the courage to do this study, which probably is very difficult to do in many centers, to give first-line treatment prior to radiation. Importantly, we have patients with neurological manifestations. In around half of the patients, they have manifested neurological problems, and the majority of the patients, they receive trastuzumab for the systemic disease. And as you know, we have the highest ever reported CNS response rate in the range of 67%, and the time to progression was 5.5 months versus 3 months if you use it late. And importantly, the responses were seen in the brain, and they were seen outside the brain, of course. And the median time to the need for radiation therapy was around 7 months. So, should this be considered standard? I wish to remind you that we don't have a standard in the NCCN guidelines or any guidelines, but probably this study, of course, it needs verification in the future. A hint for the future, it's 1 minute, that we can do a better job to improve the permeability of the blood-brain barrier. And actually, the blood-tumor barrier permeability can be improved dramatically by drugs that inhibit the phosphodiesterase enzyme. And top of the list, of course, is the Levitra and Viagra, which are used for sexual dysfunction. And actually, in the preclinical model and in animal models, we have beautiful improvement of the influx of chemotherapeutic drugs and anti-HER2 agents if you combine Levitra, specifically Levitra, with Herceptin or with lapatinib or with doxorubicin. Of course, we have suggested, my group suggested this study for GSK, and we have an approval for that. And this will start in Q3 of this year, inshallah. It will be confined to the Middle East, and we will compare in patients with brain metastasis, HER2-positive breast cancer with no prior cranial radiation. They will be randomized into lapatinib, capecitabine, like the French group, like the landscape, or the same combination with Levitra. And of course, the primary endpoint will include safety and progression-free survival. We have pharmacokinetic study will be included in this. To this end, I think the problem of blood-brain barrier, we need more to understand about the pathophysiology of the blood-brain barrier and blood-tumor barrier. And till we have a final answer, I think the use of lapatinib and capecitabine could be considered as the reasonable option against which any future therapy should be tested. And thank you for your attention.
Thank you, Dr. Hamdi. I think that we are so late. Okay, there is an announcement here.
احنا لو قفلنا النور اللي فوق ده هنخش النار ولا مش ممكن نقفل النور اللي فوق عشان اشوف الناس. تعال خد العم.
Okay, and this is an announcement, and I don't know if you know it or not. Maybe Hamdi, he is not aware of this. I strongly believe, since long time, and we have debate with Hamdi about that, lapatinib never crossed the blood-brain barrier. Now, what happens on the 12th of December, GSK released a statement, and very strong statement, that the company, they're not responsible for any speaker who's talking about lapatinib in way wide. Now, it's supposed to be the GSK, by the end of this month, release the information to all medical oncology and radiation oncology and give it to, if you have FDA in this country. What is this statement? The statement, they say clearly by the high authority of the GSK that based on the Canadian study, trastuzumab chemotherapy, which is taxane, is superior to lapatinib chemotherapy or taxane. And this has been shown in Canadian study. Importantly, that the Cerebello study, which is head-to-head, trastuzumab chemotherapy with capecitabine versus lapatinib capecitabine, which has been published in ESMO, and shown the efficacy for trastuzumab chemotherapy against lapatinib. So basically, the issue of lapatinib, I think that it is done. Now, the JSK released this statement to remove their head from punishment from the FDA and from the community in the United States.
Okay. We're not talking about the punishment by the FDA. We are talking about how you treat a case of brain metastasis. Okay. Tahir, that's not a JSK meeting. It is a conference, okay? That's not relevant to what we are saying. We're talking about the results of the data we have in brain metastasis. The Cerebello study was closed because of important issue. The number of brain events were in this particular trial was too little, and you know that, okay? Tar, we are not talking about the trastuzumab or no trastuzumab. We're talking about brain metastasis. Be confined to the subject, please.
The subject is no rule for lapatinib chemotherapy for
That's your opinion, Dr. Tahir, to agree. Tahir, you are not a JSK representative, are you? Do you represent JSK? Then don't talk about JSK, please. Tahir, that's not done. That's not done.
Okay. Now this session is closed. Thank you very much. Thank you, Dr. Hamdi. Thank you.
Thank you.